I have no financial disclosures to make. Consider all patients as potentially medical legal. Most of these cases come to court several years after the original incident, and so therefore it's vital that you document and date everything. Usually the doctor is called only for providing expert evidence, but once in a blue moon he is at the receiving end, especially when the outcomes are poor. Of particular importance are the circumstances surrounding the injury. How did the injury take place? When and where did it take place? What was the nature of the injuring agent? Was it projectile? And how much was the force applied to the globe? What was the prior treatment obtained? Evaluation of a patient involves multiple issues. The most important thing is to rule out any concomitant systemic injury. Saving the life of the patient takes precedence over ocular injury, and also stabilizing the patient prior to ocular intervention is very important. A history of drug allergies, the prior ocular status, especially prior surgery, that means you're dealing with a weakened eye, for example, cataract surgery, LASIK, RK, etc. Was the patient using spectacles or contact lenses, or was there any form of eye protection? What is the patient's last oral intake? The possibility of an intraocular foreign body and the potential for infection are very important because the situation changes dramatically. Some foreign bodies like copper and iron are capable of ocular toxicity, and the potential for infection increases much more vegetable matter than with a metal on metal strike where the foreign body may be sterile because of the heat generated. A complete evaluation is mandatory for all patients, either in the office or under anesthesia. If you want, you can give a facial block to take a good look at the eye. But fundamentally, the initial injury that you evaluate is based on the patient's capacity to cooperate and the extent of injury. But ultimately, by the time the patient leaves your care, you must have done everything. For example, even for a simple corneal tear, you must obtain an indirect ophthalmoscopy before you discharge the patient. Of vital importance is the visual acuity at the time of presentation. Obtain the visual acuity in any form whatsoever. If you can't use a Snellen's chart, you can use a near card, you can use the newspaper, you can use anything at hand to document what the vision was. Examining the pupils is also very important, especially in an unconscious patient, and also this might be the only indicator of optic nerve injury and also of intracranial pathology. The clinical examination will include any of these: a slit lamp wound examination for entrance wound, for a hypema, iris, vitreous prolapse of cataract, an intraocular pressure check if possible, indirect ophthalmoscopy if the media is not too easy, ultrasound for posterior segment trauma if you don't have any visualization, X-ray, CT and MRI based upon suspicion of a foreign body. The most vital thing that you have to establish is that is this an open globe injury or a closed globe injury? An open globe injury has to be managed surgically, whereas a closed globe you have to wait upon the circumstances. The effects on ocular tissue are many. You have both mechanical plus or minus tissue disruption with varying degrees of inflammation. The complicating factors are the presence of an infection and an intraocular foreign body. These are all some of the various consequences of trauma. Some more. And finally, the management is based upon what is involved. Is one part of the eye involved, or you have several parts of the eye? It's important to identify all aspects of the injury, and different components can be managed at different time frames based upon what's happening. Some of them deserve immediate intervention, some within 24 hours, some within 24 hours per week, and then finally the long-term consequences of ocular trauma. Immediate management is required in the following situations: for example, an orbital hemorrhage with increased intraorbital pressure, a CRAO and a CRPO, a ruptured globe, or conversely tear with a collapsed globe, optic nerve avulsion, intraocular foreign body. For observation, a small vitreous hemorrhage, orbital hemorrhage, a subconjunctival hemorrhage, a sealed lamellar tear, a small hypema, or an iridodialysis and chemotherapy can be managed medically. Within 24 hours, corneal and sterile laceration with form, globe, lid tears, subluxation to the lens, etc. Greater than 24 hours, you can wait for lid tears because of excellent vascularity, they do well. RD repair, hypema management, orbital fractures, iridodialysis and subluxated lenses. However bad the injury may be, avoid enucleation of the primary procedure. It gives time for the patient to understand the situation. It gives you time to get a second opinion and also makes you less liable medical legally. Thank you.